Hello, good evening, everyone. This is Dr. Shaher Khan. Just want to go ahead and welcome everyone. Good evening to everyone to another Facebook Live. I will go ahead and wait a couple of minutes to get the audience to join the Facebook Live. Please message or let anyone who is in the private breast implant illness support group webpage to have them come join my public Facebook page, so that not only will my private Facebook support group patients be able to see this, but anyone who is interested in learning more about breast implant illness, the way I see it, and the way that the world is slowly catching on as to what is breast implant illness. I am a board-certified plastic surgeon. I am also a board-certified general surgeon. I am basically specializing in explantation specifically, which is a removal of implants, breast implants, and the way I feel it needs to be done. And I feel strongly that this is what is going to withstand the test of time in regards to how the surgery needs to be performed in a very nice, sophisticated way, such that again, the whole gist of the conversation, the whole gist of the consultation that I have with my patients in clinic basically extends to the fact that 100% of the capsule must be removed 100% of the time, such that 0% of the capsule remains behind. So having said this, I'm just waiting to see if any of my other private group, support group patients have joined me. And I just want to go ahead and see some feedback. Let me go ahead and see. If anyone can hear me, please go ahead and let me know if you can hear. I want to go ahead and see the show of hands or any comments if you can hear me, and if I can continue on with Facebook Live. So I want to go ahead and start off by saying that, I'm going to mention briefly what I feel strongly, what are the hallmarks of what is explant surgery. The first thing, as I mentioned briefly, if I may, which is the fact that 100% of the time, 100% of the capsules must be removed along with the implant, plus any inflamed tissue, such that 0% of the capsules remain behind. That's essentially the essence and the gist of the consultation and the whole operative experience. If I may, please let my viewers know, please share the word that they can join me on my public page and not my private breast implant illness support group page, so that we can get more of an audience, so that there are other plastic surgeons, other physicians, other significant others who can listen in, and so that we maintain the privacy of the web page and also at the same time discuss with what is explant surgery. The other thing I want to highlight is what are the criteria that one looks at to make sure that the entirety of the capsule is removed. As you have heard me say this before, I'll mention what are the Khan criteria, or the criteria that emphasize or basically reaffirm the fact that the entirety of the capsule was removed. The first one is the length of time that it takes for the length of time it takes for the surgery. On average, I take 4 hours. Yesterday, I did 3 cases. My second case was approximately 5.5 hours. So you can only imagine the length of time it takes for the time. If you hear your plastic surgeon say it's going to be an hour and a half or 30 minutes each side, you certainly have this red flag, because I wish I could do it in an hour and a half. This is the way how I feel strongly it needs to be done, and there is no faster way. In this case, faster is not being smarter. Slow and basically sophisticated, nice, tedious dissection, which takes time. We're looking at approximately 4 hours that I allocate per patient, so that on average, and this is just the explantation that I do, 4 hours. The second is the length of the incision. If your incision is this small, how can you remove an implant, be it saline or silicone, that's twice the size? So the diameter of the implant essentially dictates the length of the incision. The third is the the pictures. You should get pictures not only of the capsules and the implants together, but also, more importantly, the chest wall, showing that the entire chest, most of the times the implants are above the ribs, that the entirety of the capsule has been removed. And you should actually have a video. So I do a video that shows that the entirety of the implant and capsule was removed, and that there is no residual capsule remaining behind, because that's the ultimate of proofs. And then obviously the pictures showing that the implants are on the table, the implants, the capsules have been cut, and then also that the capsules basically have pictures that show the implants themselves. I also returned the implants to the patient, which I find is an integral part of this whole closure, where the patient can actually physically feel. There's a psychological component to it, that the implant that was within the body that was creating all this havoc and all this detrimental effects to the body is physically returned to the patient, so that she can see. And there are many times where the implants don't match up with what is the card that was given to the patient, or once the patient had silicone on one side, saline on the other, or the patient was told she was going to be getting silicone implants, and lo and behold, she ended up getting saline, and vice versa. Also, the next very important criteria is the reputation of the surgeon. As you will see nowadays, there is actually a social media stamp or presence, and one can truly, I feel strongly in my mind from the feedback of the patients, the previous patients that the surgeon has had, which will validate, which will basically authenticate, which will also confirm that the surgeon is committed to truly doing the end block, and that surgeon feels strongly that the entirety of the surgery must be dependent on the entirety of the capsule plus the implant being removed, because that's where the bounce back and the quality of recovery lies. If some of the capsule is left behind, then only it is going to be compromised post-op by some of the symptoms being gone, and not all. And this is truly proven by the surgeon who is not augmenting, a board certified surgeon, because that truly proves to the patient without a shadow of doubt that the surgeon is committed to removing the whole capsule, because he sincerely believes that the entirety of the capsule must be removed for the patient to bounce back in a very nice, quick, expedited manner. Now, so if you can hear me, if you can, if you could just please basically write a comment, that would be great, just so that I can confirm that everyone's able to listen to me and everyone is able to basically hear me just well. So this is important, these 5 criteria: the time it takes for the surgery, the length of the incision, the pictures that basically need to be taken not only of the implants themselves on the table, but also the pictures of the chest wall. The implants need to be returned to the patient, absolutely. And then also the reputation of the surgeon essentially dictates over basically a period of time. He has a certain number of patients that authenticate and confirm that the surgeon is doing a good job, and that there is a check and balance on not only me but all the surgeons who explant. Now, another question that I get asked a lot is, how come you have like a 2-month wait list or 3? Now, I will tell you, I have almost 28 patients or 35 patients I've yet to call, and a whole series of patients that I have yet to discuss with, and eventually, and I'm already booked so many months in advance. I think it is unhealthy to book 6 months, 8 months, 10 months in advance, because the health of the patient changes, the nature of the breast implant illness changes, and things change for the worse or better, because sometimes the patients are rheumatological patients or cardiac patients, and it is important to kind of have a very healthy time distance. And one of the things that I also want to mention and caution my listeners is I have not advertised, marketed myself. I don't have a company that markets for me. I myself, just through Facebook Live, from word of mouth, from the patients, from my patients who basically are just talking about me. This is my one and only exposure that I have to the real world, and the Facebook Lives that I do on average like once every 3 or 4 weeks. I caution each and every one in today's world and age, it doesn't take much nowadays. You may be up to no good plastic surgeon. You may pay a Facebook group owner, And then just by donating $1,000 or a $5,000 check, that basically gets you up on the recommendation list. This is how, unfortunately, many of the plastic surgeons are buying themselves that authentication that they are true explant surgeons, where in reality you will see they're continuing to augment. And I have to say this is unprofessional, unethical, and I have to say absolutely unacceptable. And that this is an important discussion to have, where you cannot buy yourself into the explant list because you have to prove yourself over and over from one patient to another that you're taking the time and effort to do the best surgery for your patients. Now, another thing I get asked a lot by my many patients who come to me, what is it that I do? And lately I've been hearing I want to get that Khan procedure, and I will mention, which is basically the fact that I'm the only board certified plastic surgeon, number one, who has repeatedly done explants, where I will say, number one, 99.9% of my patients, especially when you have saline implants, they do not need drains. This is true also for the many patients who have normal, i.e. non-ruptured breast implants, be it silicone. And even in patients that have had ruptured silicone implants, especially proven on the MRI or an exam, I have been able to very tactfully remove the entirety of the implant and capsule as one system, which is the en bloc or the gold standard, or the 100% total capsulectomy, such that the drain usage is not required. And many patients have asked me, physicians, other plastic surgeons, how can you do the surgery without drains, where you have 300, 400, 500, 600, even 800 cc implants that I've removed? And I say, I take my sweet time, I dissect very meticulously in this avascular plane directly underneath the muscle on top of the rib, in what is majority of the cases where the implants are below the muscle, such that the need for the drain is not there, because I don't cut into the muscle, I don't leave any inflamed tissue behind, I don't leave any capsule behind, and then I dissect very carefully. And this is where the whole pressure, the whole sophisticated dissection comes into play, where I don't cut into the muscle, I don't leave anything behind, and then this leads to a better aesthetic result, better recovery, less pain, and overall a very nice, less traumatized soft tissue. This is one of the, so this year alone I have used 0 drains. Last year I can recall I used drains on only 3 patients, and they came in with essentially what was ruptured implant. As soon as I made incision on the chest, I basically saw that there was free-floating silicone that essentially committed the patient to a drain. If I'm ever sitting on the fence if I need to use a drain or not, just because of the inflammatory nature of the explantation, I will put a drain in because I can always remove. But majority of the cases, so far 100% of my cases, I have not used drains. In the many explants that I have done just this year alone, this has become exclusively my practice, to the point where I'm humbled to say I'm the only plastic surgeon in the US who is SPS board certified, and please correct me if you find anyone else who purposefully, deliberately did not augment, except for that one case, in order to get board certified, because I truly feel and believe that breast implant illness is absolutely real, and I don't want to cause any ill, harm, or any detrimental effects to any of my prospective patients in the name of what would be a very successful, financially budding practice. What is the most common plastic surgery procedure that's done by the plastic surgeons in the US and across the world, to the point where, and I caution my patients again, there are a lot of plastic surgeons who are augmenting. There are a lot of non-board certified plastic surgeons, ENT, OBGYN, dermatologists who are augmenting, and you have to be very careful who you go to. Now, the Khan procedure, number one, no use of drains. Number two, almost 80% of my patients, as you will see, do not require a lift. And most of my patients, when they see me on the first post-op, they're very much surprised by seeing their results. Their nipples, breast tissue is not pointing towards the ground, for example. That would be, by definition, grade 3 ptosis. Grade 2 would be when you would have it at an intermediate angle. And the point I'm trying to make here is the surgery can be safely and very properly done in a very nice, sophisticated way where the need for a lift is not required. Now, one thing I want to highlight, almost 95% of the plastic surgeons place the implants below the muscle. And if you look at the anatomy, You have the nipple areola, you have the breast tissue, you have the muscle, and then you have the implant, and then you have the rib, in that order, if you will. When I do my surgery, this is the 4-hour commitment that I have with my patients, you will see that the implant is below the muscle. So as soon as I make cut at the inframammary crease, which is what I do 100% of the time, I am on top of the capsule, and I remove any inflamed tissue that is in the proximity of the capsule, and I remove the capsule and the implant as one system in the en bloc fashion, preferably, or 100% total capsulectomy, such that I remove the entirety of the implant and capsule, and that dissection is below the muscle, and that is my 4-hour commitment. If you look at a mastopexy or a lift, that surgery in itself is all above the muscle, which is where you have an incision all the way around the nipple areola, and then inferiorly around the breast tissue above the muscle. In order for one to get a mastopexy or a lift or a breast reduction, if you will, that surgery in itself is a 3-4 hour commitment. So my question to the rest of the patients who get their lift and an en bloc done in 3 hours, how is this humanly possible, where you can do what is done below the muscle by me in 4 hours plus a lift in 3 hours? That's a 7-hour, 8-hour commitment, when on a day the whole surgical procedure should be focused on removal of the implant and capsule, such that those breast implant illness problems are addressed, and that the whole focus is what is essential surgery, and that the patient is given what is a non-cosmetic surgery, because the whole purpose of the operation is to remove the implant and the capsule as one system, such that there is no inflamed tissue remaining behind, and that the patient gets a fair chance to bounce back, such that when the surgery is done, you're not going to look back and say, well, I wish I had removed some more of that capsule, because that it's still in the equation. And we know definitively and convincingly the many patients who have explanted with those surgeons who claim to be explant surgeons, who tried to remove the capsule and left it behind, when the patients have gone in for a second time with another surgeon who has removed the residual capsules, then the patients find that they have bounced back to a better health. And you don't want to be that patient that came to me from Canada last week, for example. She had her surgery done by a very notable plastic surgeon in Canada, and lo and behold, she had to undergo a second surgery because that first surgeon left the capsules behind. Because that's the understanding that I have in my mind, and I know going into the surgery, this is what I know convincingly, this is where the patient's post-operative recovery and health lies. So yes, so the next, I see a remark that was made. We've been hearing a lot of women saying their doctor said tissue looked healthy, so their doctor left the capsules behind. Can you explain how this is wrong? Absolutely 100% wrong. Now I will tell you, just from my personal experience, how many times did I do the en bloc procedure at the Carmanas Cancer Center, which is the #1 cancer center at the Beaumont Royal Oak, and the many other 10 other hospitals that I rotated out of, or even when I was at Yale in my residency training, or when I was at the university hospitals in Ohio, 0 explants did I do. This is the standard of care. If any one of us basically get on a plane and go to the top 100 plastic surgery centers, be it the university centers or the major plastic surgical institutes across the country, you're going to find, if you have 10-year or 15-year-old set of implants or 5-year-old set of implants, your plastic surgeon will say, well, we're going to take this set out and we're going to go ahead and essentially replace that with another set of implants. And I will tell you that is an absolute no. Now, going back to the question, you cannot tell by visualization that this is what is a healthy capsule or what is not. Now, initially, when I was in my career, my training, I was told and I was taught by my superiors, these are the attendings who wrote textbooks after textbook and meetings after meetings, international meetings, they were the experts, that you can rupture a saline implant, and this is, believe it or not, still the standard of care in the US. You can rupture a saline implant, let all the saline out, and then through a 2-centimeter incision, or maybe 1.5 centimeter, you can go in and actually pull the entire ruptured saline implant out, or even a silicone implant, and essentially in 20 minutes suture close and call it what would be an explant. This is unfortunately, or some doctors try to, or some plastic surgeons try to remove as best as they can, as much as their eyes can see. No, you have to open up and remove. Going back to, so initially when I started my practice, I said I will not do augmentation because I don't buy and believe that the fact that the implants are safe. And I had read up enough as a biochemist in my undergrad that the implants are only notorious, replete with problems with the silicon toxicity, the gel toxicity, and what I knew in 1992 that led to the rupture and that led to the ban of the implants. Now going back to the question, so initially I said I'm just going to go ahead and remove the capsules, and if they are hard, calcified, abnormal looking, thick, only then will I remove the capsules. Then I realized as soon as I started sending the capsules off that the capsules must all be removed, because this is where, from my experience, from my looking at my patients, only when the entirety of the capsule was removed did I believe strongly, and I know convincingly, that's where the patient's bounce back lies. There are many cases of PLLC lymphoma that have not been truly diagnosed, and the number is way lower than what is projected out to be the 733 cases. So going back to what is an explant surgery in a case where the patient has lymphoma, what is the treatment? What is the surgical cure, if you will? The surgeon is mandated, required to remove the entirety of the capsule. And this is where, if you see and send the capsules off, do you realize that's where all the inflammatory tissue is, the multinuclear giant cell reaction? So it is absolutely required, 100% mandatory, that every single plastic surgeon must be devoted, committed to sending the capsules off to pathology so that they can look at it, rule out breast cancer, rule out lymphoma, rule out any of those inflammatory cells, the giant cell reaction, the macrophages, the mufome macrophages, and all those reactivity, so that we can say that certainty the patient does not have lymphoma, and that this is the root cause of the problem. And also this is proof that the pathologist has with him or her the capsule, so that if there is ever a need to go back and look, that sample is there, and also that is proof to the patient if there's ever a need, that capsule can be looked into. Many of the surgeons, unfortunately, the plastic surgeons don't send the capsules off. Number one, because they do not remove much of it. And unfortunately, I have seen this in the many operative reports that I've seen of those patients who have gone to such doctors, where an attempt was made and they said they removed half while they only removed 10%. And so it is imperative that your plastic surgeon believes wholeheartedly that the entirety of the capsule must be removed, because this is where your post-operative recovery lies. And I know this and I believe in it sincerely. And this is why I do the surgery. And this is hence what I say is the number one rule is the 100-0, which is 100% of the time, 100% of the capsule must be removed with 0% of the capsule remaining behind, and the capsule must be sent to pathology to rule out. If your plastic surgeon says that the capsule must not be sent, then we are basically doing an incomplete workup and an incomplete surgery. And if the capsules are not sent, that means they were not removed definitively, because that is another proof that the surgeon did the job right. And this is, to be blunt, needs to be done right. The worst mistake that anyone can do is to go to someone, oh, I didn't want to travel, and the next thing you know, my surgeon believes in BII. Guess what? He's still augmenting. Chances are that automatically that thought gets lost, and that is not true. If your plastic surgeon believes in BII wholeheartedly, I assure you that your plastic surgeon cannot be augmenting out of professionalism, out of ethics, and out of sincerity, because why would you want to harm someone? Now, if I may mention, could you please talk about the pathology testing on the capsules? There's a very nice Facebook Live that I did with Dr. Mowers, M-O-W-E-R-S. Please scroll back to 4 or 5 months ago. He was a guest pathologist that I interviewed directly Facebook Live, and I asked him questions, and then I went over basic details as to what is, what do the terms mean. So please, absolutely, by all means, and I will highlight it such that we can present it and the newer group members can listen to it. So essentially, the pathology, and this is where I asked the pathologist, Dr. Mowers, would you want a 22-year-old or young lady to get implants? And he said, well, as a pathologist who is looking at slides with the capsules, I would not want anyone to get implants, because every time I look at a capsule, it has a chronic inflammation, giant cell reaction, refractile, light, basically suggestive and consistent with silica. So you cannot notice grossly by looking at it and saying that, and this is, when I first was looking at some capsules when I was in training, some capsules were very benign, very super thin, and the thought was the body will absorb it, and this is the accepted norm across the country. You ask any doctor from any of these reputable top 5 hospitals, for example, all of them will say leave the capsule. And this is the whole idea behind, no, the capsule has in it the toxicities, the impurities, the silica, the burden that will continue to haunt and hurt the patient, and hence removal. And the only way you can tell is once it's removed and sent and looked at it under the microscope, and not by gross visualization. And this is essentially the gist of this Facebook Live and the gist of this whole explant surgery. What type of detox protocols do you recommend for patients after explant? Now, I'll tell you, in the world of detox, look, you have the best detox that you can do is to get the entirety, the 100% of the capsule removed, plus all inflamed tissue. Charcoal, number 1. Alkaline water, number 3. Taking these herbals that detox. All of this is not proven to be true. Otherwise, patients who have liver toxicity, or basically patients who have poor kidney function, would be taking it. There is no such thing as you take or consume infrared and that is going to detox you and remove and basically eliminate those heavy metals. That is absolutely not true. Not a single time in my career have I read this, and I strongly feel, and I know this for a fact, it is not true. Otherwise, the patients would be improving. No one would be requiring or needing explant surgery. And this is absolutely not true. All of these detox that you hear of is a, quote, lack of a better word, a propaganda. This is non-proven science. Yes, you may feel good anecdotally, but there is no hard evidence that proves that detox helps. Now, I will tell you, for me, if I have a cup of celery every day, that is the best thing. Some people say I take vitamin C tablets. I say, why don't you take an orange every day? That's going to make you feel better. Or take some lemon. That's your vitamin C for the day. Some patients say, I'll take probiotics. Well, guess what? How many people, millions of people, get colonoscopies every year? How many times does your gastroenterologist say, oh, well, have a probiotic that's going to replenish and basically replete your gut with the good flora? No. Actually, it has been shown to be detrimental in the extremes of age, the young and the elderly. So patients who get C. diff, for example, they also are not told that you have to take a probiotic. So you have to be very careful. And this is a non-regulated industry. Half of the stuff is made in China or overseas. It's not regulated. You really are not consuming anything that is definitive or fixed, that's FDA regulated. And I would not burden my soul or anyone else's body by taking what would be chalk, for example, or just pure calcium in the name of what would be, God knows what would be the toxicities that may arise as a result. Now, if someone is in their mid-50s and they have a low vitamin D level because it was quantified in the blood to be low, absolutely fair game. You can take the calcium and the vitamin D so that you have good bone health. You can get a bone density test. If your vitamin B12 level is low, or if you have had a gastric bypass, for example, you certainly need to replete and make sure that your iron stores are good and all that. So that's fair game. But for someone to say, well, I'm going to take this pill that is going to make me feel better and going to clear me of these breast implant illness symptoms, that is absolutely not reality. This is not true, and it doesn't help at all. And this is, now I will tell you, if I'm ever not sure about anything, I'll be the first person to say, I am not sure. If I'm ever not certain, I will say I do not know. We need to do more research. Now, one thing that I want to mention here is I want each and every single patient listener to go into this big MD Anderson study where they looked at 100,000 patients. This is the number 1, number 2 cancer center of the United States and probably the top 5 in the world, where they looked at 100,000 patients, 80,000 with silicone breast implants and 20,000 with saline implants, and they determined the many detrimental effects from stillbirths to basically Sjogren's, which is the dryness of the eyes, along with the many signs and symptoms of breast implant illness. So this is a very nice, it's a study of studies. It is accumulation of studies. It's a special study, but at least it's the biggest study after 2007 when the implants were allowed back into the market under experimental conditions, where they have proven what are the follow-up studies that show the detrimental effects of breast implant illness. Can you have an end block total capsulectomy through the original augmentation scar, either areola or first anchor lollipop scar? Now, remember, a small areola incision is this much. How can you remove a 300, 400, 500 cc implant? How can you even dissect off of the rib cage? That is impossible, and I will use the word impossible. How can you dissect through a small hole directly on top of the rib? I make such a nice, generous incision at the inframammary crease, and I'm looking at it wide, and through my fingers am I only retracting the implant off of the rib, and I'm dissecting very meticulously. That is the visualization I need. I cannot operate from the top of a tent, if you will, where the nipple areola is, and to be able to dissect down through a nipple areola, or even in a straight up and down incision through the breast tissue. Now, one thing I don't like to do is to go up and down through the breast. So just imagine going back to the anatomy. You have the nipple areola, you have the breast tissue, you have the muscle, and then you have the implant, and then you have the ribs. Why would you want to cut through the nipple areola? You have the ducts that are not truly sterile. You have someone wants to breastfeed, she's 26. You don't want to cut her ducts, i.e. the nipple areola. The next thing you know, she cannot breastfeed, at least the lower inferior aspect. Number 2, you cut the nerves. Number 3, you put a scar in the center of the chest. Number 4, you have to go through the entire breast tissue to dissect down to the muscle. So now you basically cut through the breast tissue, and the patient may end up getting a basically fat necrosis, or the glandular, when the suture close, an irregularity that might show up on a mammogram or an ultrasound, or some irregularity of a scar that may potentially precipitate an unneeded biopsy. And then you cut through the muscle, and then you get to the implant. And then how can you get the visualization to removing the entirety of the capsule plus the implant that's sitting tightly on top of the rib cage? That's a very, what I would use the word, poor, inefficient, and replete with problem approach. Why don't you just make an incision right at the junction of the breast and the chest wall, such that you get the best visualization? You elevate, you're away from the rest of the muscle, you don't have to cut through the breast tissue, the nipple areola, and that way you get the best access. And the whole commitment, if you go back to the first part of the Facebook Live, should be and must be to removing the entirety of the implant and capsule in a very sophisticated way, such that no capsule is left behind. And I will tell you, as a surgeon, if I were to dissect through in and around the nipple areola or the breast tissue, I cannot dissect safely and completely and definitively, unless that incision is going to be way too big, which is not what I'm able to achieve if I make an incision at the bottom. Next question, I'm just going to scroll up. No, I just want to thank everyone. Yesterday I had a very long day. I was physically at the clinic at 6:15 in the morning. I didn't leave till approximately 9 p.m. Yesterday, and I did only 3 explants. I thank the many ladies that have entrusted me and that continue to be basically part of the journey from the beginning to the end, that have watched my Facebook Lives. When they come to me, they understand how I do it. Another thing I recommend and encourage all the plastic surgeons who are explanting, you should do a Facebook Live with your patients, so that the other patients understand how you're doing it, why you're doing it, so you can answer the questions. Because as a patient, you want to see what's in my mind, how committed am I into removing the entirety of the capsule. And like me, all the plastic surgeons need to be talking about a topic that's not described at all in any of the textbooks, that's usually not talked about much at any of the conferences. And this is a topic that only is going to become more and more important and significant, and a day-to-day discussion. I'm very happy to say last Thursday, 6 days ago, we were delighted to have Channel 7 News, which is the major news channel here in the city of Detroit. Miss Carolyn Clifford, she's the head news anchor. She was the health spokesperson and the news anchor. She came into the OR physically She was very nice in the sense that she was very much wanting to understand how I, as a board certified plastic surgeon, do my surgeries, and why is it that patients from Egypt, from the Dominican, from Germany, Japan, from the rest of the world, from Panama, from literally every state of the US, from Canada, they come to me, and why is it that I do what I do? And she was able to physically hold the capsule in her hand, and she was, lack of a better word, aghast, shocked, totally caught by surprise by the texture of the capsule that she held, by the calcification of that capsule, and for her to be able to see how I make the incision, how I do the surgery start to finish, and how I'm very much involved from start to finish in regards to how I do my surgeries. So we will have that news article, documentary, or the clipping that they have. We did Grand Rapids, 2 hours away from here, another news basically presentation where they basically followed two of my patients, and that was basically presented a couple of months ago, soon after the New Year's, 3 months ago or so. We have another documentary coming out of California. There is the Scrubs magazine. They actually flew twice from California all the way from Los Angeles, which is the major plastic surgery capital of the world, to none other than snowy Novi, Michigan, where they brought two patients each time, one in November of 19 and then February 18th of 2020. Two patients that they physically videotaped inside the operating room as to why and how I dissect. And they actually are doing a documentary in regards to what is breast implant illness, and which is what the world is going to be talking about very soon. And hopefully a very, informative documentary so that the patients can understand and relate to what is breast implant illness, which is real. And such that hopefully one day, that day is not far, when the implants will get banned, again, for the betterment of the ladies, their significant others, their friends, their lives, and the betterment of mankind. And that truly will be the best thing that would happen in regards to what is the many sad and the detrimental effects of breast implant illness. Now, the other thing I want to mention is going back to the Khan procedure. It is very important, number one, that the drains not be placed because they're not required when the surgery is done right. This is part of the Khan procedure that I've talked about earlier. Number two, the implants must be returned 100% of the time. I always 100% of the time take microbiology cultures from the right chest and the left chest and send to the microbiology lab. I want to know it's not mold. I want to know it's not bacteria. I 100% of the time take pictures of not only the implant and the capsules, but also the chest wall, showing that I've done it. 100% of the time I'm focused on more of removal of the implant definitively, be it the 4, 5, 6 hours that I've taken, 6.5 hours I've taken, and such that I remove the entirety of the capsule and the implant plus any inflamed tissue, leaving none of that behind, because that is the essence of what is explant surgery. And I will tell you, 20 years from now, I cannot imagine the surgery being done in any other way other than what I've described as such, without the need for drains, without the quick or the fast way that many of the plastic surgeons unfortunately are doing it, that mandate now drains, and that the patient's bouncing back maybe 40, 70, 80%, but not definitively and not completely. It must be firm in the mind. And so this is basically very important to mention to the patients what is and why I do the way I do. And I have a track record of having done so many surgeries in a very nice, sophisticated way. Now, next question. Have you had cases where the tissue adheres to the muscle and leaves a deformity? So the goal here is to dissect off the muscle and off of the rib. Now, in this case, when the implant is tightly adherent to the rib, the dissection is done such that the fascia of the rib is removed along with the capsule. Because if you leave that behind, you're going to leave the impurity behind. So you will see in majority of my, in all of my post-op, or in my most of my the videos that I've done of the chest wall, that will be void minus the fascia of the intercostal, such that the entirety of the rib will be free of the periosteum, which is the layer directly on top of the rib. Now, one thing I mentioned, like on the, if you have a charcoal grill and you leave like a piece of meat on it, it will stay on if you burn or cauterize it. That is not good enough, because after some time, the burnt cauterized tissue will get absorbed, cleaned up by the body, and you will have residual capsule behind, and that is the whole purpose behind. So the capsule has to physically be eliminated, removed, deleted, excised off of the rib in this very sophisticated way. It cannot be left behind. So you don't burn on the rib, you physically peel off. You literally eliminate or remove that capsule. It is not good enough just to bovie or burn it. Or like one of the other plastic surgeons, she took an argon beam. This is what they use in liver surgery when liver bleeds a lot. So they basically burn, like it's like a Bunsen burner, if you will. It's a beam, it's an argon beam that essentially burns all that liver such that it coagulates and does not bleed. That is not good enough where you basically argon beam the chest. You have to physically remove it. Are some labs better than others as far as how detailed testing they do? Now, I will tell you, one of my patients came and she said, I want my labs to go to Quest. Now, Quest is the #2 lab in the US that processes lab samples, everything else. But when it comes to the pathologist, if you can imagine a small hospital in the middle of nowhere, for example, that receives a capsule. Now, they will be able to rule out breast cancer. They will be able to rule out what is a common day-to-day occurrence. But when it comes to the capsules, my team of pathologists out of the big Providence hospital, the Accession system, which is a major hospital system of the US, I know Dr. Govil, Dr. Mowers, Dr. Mervek, and all of these, Dr. Farouk Minhas. I know them personally, and I know them because last week I did 2 cases on Monday, 3 on Tuesday, 2 on Wednesday, 3 on Thursday, 10 cases, and they receive so many, and every week they receive at least 6, 7, 8 samples. And they have been doing it for the longest time, and they know what they're looking out for, and we're looking for, and I talked to Dr. Govil. I said, I want you to refract light, and I want you to tell me if there is crystals of what would be silica. I want you to, and so they know what I anticipate, they know what I want as a board-certified plastic surgeon, because not every pathologist was refracting light onto what would be those hard crystals that you see. And the bottom line here is, I have had to educate through one pathologist as to why I want to do what tests, what am I looking for. For example, some of the tests don't even have the capacity for CD30 analysis, which is the major lymphoma marker. And this is where the sophisticated high-tech lab where you have a department. So if you look at the Department of Pathology, you don't have 2 pathologists working. You have a team of pathologists. So one specialty is breast, one specialty is skin, one specialty is neuro. So they can look and basically bounce off each other, which is very normal. And it's not uncommon where one of my patients had a questionable lymphocyte. Guess what? I sent those labs and those slides over to the Carmanis Cancer Center. They looked at that and they said, by a second set of minds, that it was not lymphoma, and I just wanted to be certain. And this has happened actually twice. So the point being, you have to have a group of trained pathologists who are looking for something. The eyes don't see what the mind doesn't know, and if you're not doing it routinely, you're going to miss something. Now, we live in the Motor City. If I may use this example, same thing applies to explant surgery. Oh, how many explant surgeons have you done? You have to go to someone who does them exclusively, such as myself. Now, if you ask me to do a nose, I'm going to be the first person to say, not me, I'm not your guy. You have to go to the plastic surgeon who has done 3,000, 5,000 noses, because the rhinoplasty is the hardest part, if you ask me, of the face. Now, going back to, we live in a Motor City, and this is what my mentor told me. If you have a car transmission problem, you want to go to the transmission expert who does transmissions from 8 in the morning till 6 p.m. every single day. And all what he knows is transmissions. He cannot build the engine. He cannot do brakes. And all what he knows and fixated on is transmission. He'll tell you everything possible. This is, plastic surgery has 3,000 procedures, literally, from the cleft lip pellet to the craniofacial. With the pediatric, you have burns, you have skin cancer, you have lower extremity reconstruction, you have oncologic reconstruction, breast reconstruction, you have hands. Many of my patients ask me, I thought you were a hand surgeon. No, all plastic surgeons are hand surgeons. They choose not to do hand because they're focused mainly on breast, because this is where the augmentations get them the the financial reward is the most. And the point I'm trying to make here is, so you have to go to someone who deals primarily, and just like with pathology, to the pathology lab that processes it routinely. And the same surgeon who is doing explants routinely is because he's the expert. He can talk about it. He can vocalize and discuss and say, you know what, many of the times I've heard some of my patients say, well, my surgeon told me I'll decide in the OR what I'm going to do. That's a big red flag. My insurance is going to take and cover this. I'm so lucky. I'm so blessed. No, 100% of the time, if that is what you're hearing, 100% of the time, your plastic surgeon is going to do that quick 30-minute operation where he's just going to remove the implant, leave the capsule behind, because the amount of money that's basically given for removal of the implant and the capsule is in the order of maybe 500, 600, 700, 800, pushing 1200. It will not justify removing off the implanted capsule and the 4-hour commitment that I do. And nowadays, mark my words, any private doctor who is taking insurance cannot support a practice that is healthy and honest. And that is the harsh reality of what is the #1 reason for bankruptcy in the United States, which is medical bills. And I will tell you, almost a quarter of the hospitals are in trouble in the US because of their financial ability. And all of these hospitals are financial institutions. Just ask any nurse, anyone who's worked in administration, or any doctor, they will tell you the hospital is replete with problems when it comes to them being a money-making business at the expense of the patient's health, period. Quote me on this, and I'm telling you this is a reality. This is where you have a colonoscopy reimbursing a gastroenterologist $205.76. You cannot do 100 colonoscopies in a day to justify the overhead of a private practice. You have to be working for a big group. You cannot be a general surgeon doing appendectomies for $300 because you cannot float a practice with that type of a refund. And unfortunately, this is where American medicine has led to. In the 80s, it was a different game. The insurances were nice. There was no deductibles. There was what you got basically was premium service. Nowadays, it's totally different. This is nowadays, if you go to a doctor's office, you have nurse practitioners and PAs running the show. Unfortunately, you're lucky if you see the MD, and if you do, you'll be lucky if you see him but for a few minutes. And unfortunately, that's the harsh reality of what is American medicine now. And I say this very bluntly, but this is reality, and you'll accept the fact if you talk to anyone in medicine. Now, the next thing that I see here is my nice patient from Florida. God bless you, the nicest patient, and her nice, very nice son that came over for her pre-op and post-op. The next question I have is, can you have an end block total capsulectomy through the original? So this is, I don't like incisions around the nipple areola because of the reason that I mentioned earlier. What happens when your capsules are stuck to the ribs? Are you still able to always remove them safely? Yes. Yes, I am. I am able to remove them safely. I sometimes, and I say this to my patients, on the medial or the mid part of the chest, you have sometimes, especially in the younger ladies, some cartilage. I'm able to burn some of that cartilage in order to remove the capsule definitively. When I have the bovie in my hand, I'm able to use that bovie cautery to burn directly off of the bone. So I do that routinely if the capsule is tightly adherent, but 100% of the capsule is physically removed. And you can imagine if I'm dissecting with the bovie directly on top of, let's say, for example, the femur, right? The long bone of the leg, I can remove the periosteum, which is the layer directly on top of the bone, and leave the bone void, i.e. minus the capsule or minus the periosteum. That is exactly what I do. And this is why this is such a dangerous surgery. And I'll tell you, if you go to 100 plastic surgeons, from my experience of talking to so many plastic surgeons and colleagues and other patients who have gone, the plastic surgeons themselves will 90% say 90% of them will feel uncomfortable dissecting and removing the entirety of the capsules because, number one, they feel that is not required. Number two, it's unsafe, and they put the patient at risk for what would be a pneumothorax, which is air in the lung cavity. So do you ever cauterize the scar tissue of the ribs? Absolutely. So I dissect, like I mentioned, directly on top of the bone such that I'm elevating, burning, and removing that periosteum off the rib or the cartilage and physically eliminating, removing, such that all what you have is literally raw bone remaining behind. And you will see that in the many pictures. You will see the black marks which are cauterized on the many videos that I give to the patients. So can you tell me how big the scar is below the breast? Now, I'll tell you, there's one time a patient that came in, the diameter of the implant essentially dictates, remember when I make an incision at the bottom, I have to be able to dissect. So one patient came, she had a grade 4 contracture of the implant in the capsule, very hard, and it was riding all the way up into the chest. I made an incision this big. Guess what? It was not good enough. I couldn't see the top. I didn't want to dissect all the way up here. It was tightly adherent. I made the incision a centimeter bigger. Guess what? I was still having a challenge. I said, you know what? I'm going to make it another half a centimeter bigger. And that half a centimeter meant the world to my dissection. That meant a world to my dissection. And I was able to visualize 100% definitively with my headlight, with my loops, the special magnifying glasses. And I was able to convincingly 100% under direct visualization remove the entirety of the capsule safely. And so I have to say, absolutely, it is fair game, and it is truly the right thing to do. You don't want to do, like one of my plastic surgery friends said, wow, that's a pretty big, generous incision. I said, you bet. What is the purpose of your surgery? To make the patient look pretty and have her have a low scar that's going to hide nicely in the crease? Or are you interested in her basically being free of all those breast implant illness problems? What is your goal? That means you're not buying. I saw a pre-op record, a pre-op note on a patient that said pre-op diagnosis, possible breast implant illness. I'll tell you, how can you be possible breast implant illness and truly be committed to removing the whole capsule? It's just like saying if you're at the top of a ski slope and a jump and you're about to undertake a very big leap, i.e. in the air, and do a long jump through this, ski jump, the long ski jump. And if you're a little bit shaky, you're going to land on your face. This is the same thing. If you're not committed to removing the entirety of the capsules and you're not sure about what is even a diagnosis, you're never going to do the surgery. And this is unfortunately what happens when the going gets tough and the plastic surgeon initially, who's very enthusiastic and says, well, I'll let go of my ego and I'll do as you wish. And then when the going gets tough in the OR, they're like, well, for the betterment of the patient, I'm going to leave that behind because I don't want to jeopardize her health and potentially put her at risk for what would be involved surgery. I'm just going to go ahead and look at some of the notes that I made. Now, another thing that I want to mention here is, I want to go ahead and wrap this up in 10-15 minutes. One patient came to me. She came to me referred by none other than what is an emergency room doctor, and I was totally surprised. She went in, she had shortness of breath, some chest pain. Guess what? Young lady in her low 30s. 33, I believe is how old she was. She went to the emergency room. They did a CT scan of the chest, and lo and behold, they said, you don't have a pulmonary embolus, which is a clot in the lung. But guess what? The emergency room doc went to the patient and said, she's told me, the doc closed the door and said, I think you have breast implant illness. You need to go see Khan. He'll take care of you. And this was right at the hospital next door. Or you need to go see and this is what is a game changer. Here, the emergency room doc, who's like a gateway physician, diverted the patient to me and said that this is what your breast implant illness is, and this is what just the problem. And he was able to, without any by diagnosis of exclusion, because he had read up and he had heard. Now there are primary care doctors, rheumatologists, and the patients educating the doctors in regards to what is breast implant illness. The more we talk about it, Miss Pugh, P-U-G-H, Miss Pugh was over in the second last Facebook Live. The state of Michigan and Lansing, they're going to pass legislation where they're going to highlight what is the FDA that highlighted what are the three important points. Number one, the implants. The FDA in September 29th or the first week of October of 2020 highlighted these very three important points. Number one, and I want each one of you to look this up. Number one, they said the breast implants are not meant to be in the body forever. They last on average 10 to 15 years. This in itself should be a red flag for everyone. Imagine you're 20 and you're told that every 10 years they need to be replaced and you need more surgery. That should be a red flag. Number two, the breast implants are associated, and I want you to read the language and read between the lines. You will be very much surprised. The FDA put forth a warning. The second warning was that the breast implants are associated with breast implant associated anaplastic large cell lymphoma, and it is primarily the textured implants that are responsible and notorious, and that there is a direct cause effect as a result of getting the textured implants. They result in what is lymphoma in the 733 patients that ultimately led to the ban of the textured implants in France and ultimately the US. And what is interesting to note, they mention in other implants, i.e. smooth. So they are also important, and they are also the notorious, i.e. for causing lymphoma. So it is not only the texture but also the smooth, but to a much lesser extent, and they do not know to what capacity do they cause, i.e. the smooth implants cause lymphoma. And this is not a scare. This is an important statistic, and this is an important finding that they put forth. And the third thing, they acknowledge what is breast implant illness, the many signs, symptoms, the hallmark features, the rheumatological brain fog, the neck and back pain, the many problems of vision, GI problems that they said that truly exist, and that the patients who sign up for or are wanting to get augmented need to be aware that this is what is to be expected. If you ever do get sick, this is where you can go and seek help. And so basically the state of Michigan is going to pass legislation that is going to require, mandate that the plastic surgeon discuss with their prospective patients who are going to get augmented that these are the detrimental effects of what is breast implant illness. Now, what I want to do is I want to go ahead and answer a couple more questions, and then I will go ahead and end this Facebook Live. Hopefully you found this informative. I want all my patients, all other patients, even patients who are in other parts of the world, to basically go through this Facebook Live, the other Facebook Lives, my YouTube videos, and see why and how I do it differently, and why I believe strongly that this is the take-home message. The entirety of the capsule, the 100-100-0 rule, 100% of the time, 100% of the capsule must be removed, because this is where your bounce back is. This is where you can say at least the implant and capsules are out of the equation. Now this is me. This is what may be my rheumatological issues, or my MS, or my bad Hashimoto's that might be acting up, or at least will be fine-tuned such that my immune system is not in haywire. Now, any other questions, please? I'm going to go scroll back. So in regards to the muscle repair, now what I want to do here is, if you look at, now I'm going to go ahead and I mentioned this in regards to muscle repair. Now I'm going to go ahead and go into, I have another phone that I'm going to show you, just so that in the interest of discussion, and I show this to all my patients. So if you look at this, this is the pectoralis muscle, the pec major. As you can see, this covers the entirety of the chest, and it inserts, as you can see in blue, it inserts into the upper arm, the humerus. Now, whenever I make the incision at the bottom, right here, at the bottom. What do I do to the rest of the muscle? I don't cut up and down, so I'm cutting through the muscle. I make the cut at the very bottom. And then what do I do? Excuse me. What do I do? I make the cut at the very bottom right here. This is my inframammary crease, and then I ride the muscle up such that I leave the rest of the muscle alone, because I don't need to disturb it. If I cut into the muscle, guess what? It's going to bleed. Muscle bleeds. All the blood supplies to the muscle. And I don't want to touch the muscle. I have nothing to do with the muscle. The implant is below the muscle. And this is where, when I dissect below the muscle on top of the capsule, such that that very fine line, i.e. the fascia of the pectoralis at the inferior aspect, and the implant, the capsule that's sitting directly on top, that's that avascular, that bloodless plane that I dissect into, such that I'm able to leave this muscle alone. Now imagine if I was going to the nipple areola, I would have to make a cut through the muscle, and then I'm obligated in repairing the muscle. In this case, if I go at the bottom, I don't need to repair the muscle in majority of the cases. Only when and those surgeons who go through the nipple areola, number one, they're not going to have the optimal visualization, or if they are doing a lift up and down, then they're cutting through the muscle, and then you have to repair the muscle. So I don't like to cut the muscle, because I don't have to repair it, and no matter how you repair it, you will not be able to let the muscle heal if you are going to cut through it. The best way to do it is don't touch the muscle, because then you won't have to repair it. So if that helps and makes sense. The muscle will not heal on its own. If you cut the muscle, it's going to get attenuated. It's not going to have the muscle fibers to heal. So that's why leaving the muscle alone is the best option. I have interstitial cystitis. Can this be caused by textured saline implants? Now I will tell you, now I want you to go to my Facebook page. Now I'm always learning from my patients. They will tell you, go to my Facebook page and you ask how many of you have had to go repeatedly to the bathroom and they had interstitial cystitis, they were getting chronic UTIs. How many of the ladies post-explant improved on their urinary symptoms and their interest, and you will be surprised to see, and their answers right there in my Facebook. There is a lady that went and said, I've had almost 30 UTIs in my last 7 years that I've had, or 10 years I've had the implants. This is what she mentioned. And ever since, she's had no problems. And you will see, certainly there is an association. And if you ask that question in my Facebook private breast implant illness support group, you will see the answer right there. Yes, there is that association that my patients have told me convincingly the many times that it exists. You know, this is just like saying that, you know, one of my patients, she's a nurse in Columbus, Ohio. She was taking her 3.5-hour drive back home. And she said, well, she was going home and her husband was driving. She could read the newspaper, the magazine, the signs better. And I said, that's BII. I told a friend of mine who's a plastic surgeon in the suburbs of Los Angeles, this is my patient. She's going home and her eyesight is improved. It's what the patients are saying, high definition. I can see clear. It's not blurry. I don't even have to wear the glasses. When I told my plastic surgery colleague, my friend, my good friend, he said, well, this sounds so weird. How can you remove implants and the vision improves? And I said, this is breast implant illness for you. And he said to me, and I'll be candid, he said, your patients are weird, and the fact that you believe your patients you're weird, how can you remove implants and the vision improves? And I said, well, this is the magic of doing the explant surgery right. And if you listen to enough patients, you will be convinced yourself, because this is as real as any other illness. So now going back to, I want to go ahead and I want to highlight, I want all my patients, all the patients who are listening, many patients, you know, and again, I can only do 300, 400 of these operations a year. I cannot do more than 3 max. I have had a couple of my patients, my nurses actually leave because my hours were too long. And the point I'm trying to make here is this is a very defined problem with a very defined solution. Once the patient has seen their primary care doctor and all those other problems have been ruled out, those cardiac issues, rheumatological problems, that workup for MS, Lyme disease, all of that has been done and negative, and the doctor says, what are you talking about? You're in great health. You've got fibromyalgia and you don't need anything but a psychiatrist because you're overly stressed. You got 5 kids, you're hit menopause, you're getting old, and you know deep down within your heart that this is what is breast implant illness, because you have related to another patient who said that once she got her implants out right, that she bounced back to her better herself when it came to her health. And the point I'm trying to make here is once those other problems are ruled out, then we can say definitively and convincingly that these are the implants till proven otherwise. And one thing is for sure, and I'll end with this. The implants are only replete with problems. Number one, the fact that the implant goes below the pec muscle compromises the pectoralis, so truly you cannot use your upper extremity strength to the point where the shoulder gets destabilized, because as you saw, the muscle humerus inserts, the pectoralis inserts into the humerus, and then the function of the upper shoulder is compromised, because every time you would use the upper extremity, i.e. flexion of the biceps, you would inevitably compress the implants and the patient would feel uncomfortable. Number two, the implants are only replete with capsular contracture that occurs in many studies that show anywhere from 3 to 7, 10% of the patients. Infection, they are associated with lymphoma, they're associated with almost 100% of the patients get breast implant illness, because remember, the implants are not meant to be in the body forever. You're not going to find a single reputable board-certified plastic surgeon who will put down on paper that the implants last forever. They only last What the FDA has mentioned 10 to 15 years, I say on average 7 to 10 years before they start becoming reactive. As you know, the implants are associated with infection, as I mentioned earlier, contracture. They're associated with rippling. They're associated with bottoming out. They're associated with the next thing, the self-monthly breast exam, where the patient now is not able to feel what would be breast cancer because the implant was getting in the way, or she had a contracture. And many patients are now reluctant or feel uncomfortable getting a mammogram because they feel that when they go and get the mammogram, that will put undue pressure onto the implant and potential rupture. And guess what? There are many breast cancers that are not being picked up because the mammograms are not being done. The implants are only replete with problems. As you have seen, they've been banned before, and look at all these warnings and all these patients coming forth. And I say, with my humble opinion, my humble expertise, that basically the implants are not safe, they are not effective, and they should not, at the sake of health, compromise and steal from the patient's life, and not only the patient's quality of life, but everyone around them. And I will say that we should put a halt to the augmentation, and that more research and studies need to be done. And I cannot imagine ever, this is just like saying cigarettes are safe. You cannot say the implants are safe, be it saline and silicone. And that hopefully there will come a time where the many patients who are out there who are hurting will realize one day it was always the implants and nothing but the implants, and that they get the right surgery done so that they get a right bounce back to their normal good health, so their body is in equilibrium with themselves, and such that they basically go back to enjoying life and going back to living a better health, such that they can breathe healthy, they can live healthy, and they can truly enjoy what would be a world and life without the breast implant illness. Having said this, thank you again very much. Hopefully you found this informative. Till next time we meet again. God bless everyone. Stay safe, and I wish you everyone the best. Thank you again. Bye-bye.